Hello, I'm Manoj Karmakar. In this next video, Professor Boezaart from Cape Town in South Africa is going to present his arguments for the motion that thoracic epidural anesthesia or analgesia should be the technique of choice for unilateral pain or surgical procedures in the thorax. If you're enjoying our videos, do remember to like and share these videos with your friends and colleagues. Also, if you still haven't subscribed, do remember to subscribe so that you can get regular notifications from ISSPS TV of any future uploads.
My name is Boezaart, originally from the Pain Service of the University of Florida, and now working for Lumina Health Pain Medicine Collaborative. I have no applicable disclosures, and again I thank Professor Karmakar and the organizing committee for inviting me to participate in this debate section. The question is whether epidural anesthesia, fascial plane blocks or thoracic paravertebral blocks are the most appropriate for the post-op analgesia of thoracic surgery. Obviously, as everybody knows, there is no one-size-fits-all to answer this question, and every one of these regional anesthesia modalities has its own list of pros and cons. My task is to focus on thoracic epidural anesthesia and analgesia, and that it should be the technique of choice for unilateral pain or surgical procedures in the thoracic area. Thoracic epidurals used to be very popular in the 1980s and 90s, but now has fallen from popularity among surgeons because they claim that the thoracic epidurals don't work, and it introduces complexity for the care team because of the hypotension that it causes. But as we know, for regional anesthesia to be successful, you need 5 things. You need the correct indication for the block. You need to block the correct nerves. And although this sounds simplistic, from real-life situations, we have all seen actual cases of lumbar epidurals that were performed for laparotomy or thoracotomy, and we all know that these are pretty useless. Number 3 is the use of the correct technique. Number 4 is the correct equipment. For example, thin sharp needles around the dura is dangerous. Number 5, we have to have the correct recipient of the block, and this should not be the PACU nurse, the surgeon, the institution, your partners. It can only be the patient. So let us start with the correct indications. To answer the question of the correct indication, you have to ask yourself, what am I doing? Why am I doing it? Who am I doing it for? What are the risks and what are the benefits? You first have to convince yourself of these questions and then the patient, which right there gives you 100% informed consent. Let us look at a few examples of this. I'm asking myself, what am I doing? I'm doing a thoracic epidural block. Why am I doing that? I'm doing it for unilateral minor breast surgery. Who am I doing it for? I'm doing it on the surgeon's request. What are the risks? We all know the risks of thoracic epidurals. And what are the benefits? We have good pain control. But this is the wrong indication. Unilateral thoracic paravertebral block is a better choice than thoracic epidural for this specific indication, and no block at all may even be a better choice. Another indication, what am I doing? I'm doing a thoracic epidural block for unilateral major breast surgery. Who am I doing it for? The surgeon's request. What are the risks? All the risks associated with thoracic epidural block. And what are the benefits? That's obviously good pain relief. Again, this is the wrong indication. because unilateral thoracic paravertebral block is most likely a much better choice. There are no visceral receptors in the breast. What am I doing? I'm doing a continuous thoracic paravertebral block or a continuous erectospinae plane block. I'm doing this for a thoracotomy involving the lung and the visceral pleura. Who am I doing it for? Again, the surgeon's request. What are the risks? Much less than thoracic epidural analgesia or anesthesia, we may argue, although I don't agree with that. What are the benefits? Great somatic analgesia. Again, wrong indications. We need visceral and somatic block for this indication because we are involving the visceral pleura. The same goes for laparotomy, where we have to involve visceral pain, and a thoracic paravertebral block or a erectospinae plane block does not block pain coming from the viscera. I'm doing a thoracic epidural block. Why am I doing it? I'm doing it for bilateral lung transplant, again surgeon's request, and again all the risks of thoracic epidural block. What are the benefits? Somatic and visceral pain, but it's again the wrong indication because the lung and visceral pleura had been denervated. The lung has been taken out, denervated, and a brand new lung has been transplanted. Visceral block is thus not needed, and bilateral thoracic paravertebral block is a better choice. What am I doing? A thoracic epidural block for multiple rib fractures with no pleural involvement. And this multiple rib fractures can be unilateral or bilateral, again surgeon's request, and again all the risks associated with thoracic epidural block. What are the benefits? Great visceral and somatic analgesia. Again, the wrong indication because we block the visceral and the somatic pain, but there is no visceral pain. Continuous thoracic paravertebral block is again a much better choice in this scenario. What am I doing? Again, a thoracic epidural block, multiple rib fractures, extensive parietal and visceral pleura involvement, bilateral or unilateral. Again, the surgeon's request. Again, all the epidural risks, and we have great visceral and somatic analgesia. Now, this is a great indication because we block the visceral and the somatic pain with the thoracic epidural block. So let's move on to blocking the correct nerves. Here we have to go and have a look at Anatomy 201. How does thoracic pain get to the brain? Somatic pain from the thoracic area and the abdomen gets to the spinal cord and brain via the intercostal nerves. These are somatic nerves. Now, how does visceral pain get to the brain from the abdomen? Visceral pain from the abdomen goes via the preaortic ganglia and splanchnic nerves to nerves associated with the sympathetic trunk. We used to think that these nerves associated with the sympathetic trunks are sympathetic nerves, but it has been shown lately that they are not sympathetic nerves, they are just associated with the sympathetic trunk. So how does visceral pain get to the brain from the thoracic area? And again, this pain of the thoracic viscera gets to the brain via the sympathetic ganglia, again with nerves associated with the sympathetic nerves, not via the sympathetic nerves themselves. Viscera originate embryologically from midline structures. It thus has bilateral innervation. Visceral pain has incorrectly been assumed to be sympathetic because afferent fibers are anatomically associated with the sympathetic division of the autonomic nervous system. Visceral pain is also perceived as more unpleasant than somatic pain and found to be more fear-evoking than somatic pain. Parietal peritoneum and most likely parietal pleura has somatic and visceral afferent innervation, as shown by this paper from Pleura and Peritoneum 2017. As can be seen from this same publication, visceral peritoneum and most likely visceral pleura has no innervation, but submesothelial tissue is innervated by the parasympathetic nerves, in other words the vagus nerves, and nerves associated with the sympathetic nerves. So, cell bodies of the spinal afferent nerves that are anatomically associated with the sympathetic nerves can look like this animation. The paravertebral ganglion is depicted in yellow here, the preganglionic sympathetic nerves in light blue synapse in intermediate lateral nucleus of the spinal cord and leaves the spine via the anterior spinal root to enter the paravertebral sympathetic ganglion. Incoming splanchnic visceral branches, the white lines on this illustration, traverse the sympathetic ganglion en route to the dorsal root ganglion and spinal cord. They may branch and send off collaterals that synapse with the prevertebral ganglion neurons. It is also becoming increasingly evident that bone pain and ischemic pain behave more like visceral pain than somatic pain. Bone pain, such as from rib fractures, are most likely also visceral pain, but we don't know this for sure yet. What we do know is that the parietal pleura also has visceral innervation that travel to the brain via the nerves associated with the sympathetic nerves. A recent important paper by Vahal et al. Demonstrated that ischemic pain and visceral pain have a shared anatomic conduction pathway, namely sympathetically mediated perivascular A delta and C fibers. Ischemic pain should thus also be viewed as a form of visceral pain. So requirement number 3 and 4 for effective regional anesthesia, we need to use the correct technique and we also need to use the correct equipment to make it work. In 1995, there was a big push to the revitalization of thoracic paravertebral block. The question now is if thoracic epidural block is now where thoracic paravertebral block was in 1995. In 1979, Easton and Wyatt quoted from the then current literature and stated that thoracic paravertebral block is now of more interest to historians than to practical anesthesiologists, and they called for its reappraisal. In 2001, Professor Longquist called thoracic paravertebral block the sleeping beauty. My colleagues and I from the University of Iowa at the time also visited this in an editorial called Sleeping Beauty or Big Bad Wolf, and we wrote a paper on continuous thoracic paravertebral block for major breast surgery. Thoracic paravertebral block was called the Big Bad Wolf because in 1979 it was argued that there was a lack of absolute indications for thoracic paravertebral block. There was a familiarity with thoracic epidural block and the omnipresence of adverse effects at that stage, pneumothorax and subarachnoid injection. Are we now with thoracic epidural analgesia or anesthesia where thoracic paravertebral block was in 1995? Is it now time to revitalize the thoracic epidural block? And now in 2021, the thoracic epidural block is viewed as the big bad wolf because of exactly the same reasons. Lack of understood indications for thoracic epidural block, relative familiarity with thoracic paravertebral block and the omnipresence of adverse effects, namely mainly hypotension and block failure. It was argued in 2002 that adding nerve stimulation to paravertebral blocks make them safer, and now obviously ultrasound makes it even more safe. The epidural failure rate is anything between 15 and 30%. Also, unilateral epidural block is as high as 15%, and these are related to epidural blood vessel, the plica mediana dorsalis, and anterior Hoffman ligaments. We have recently argued that unilateral epidural can also be related to prelaminar fibrous bodies. These bodies were not known to us prior to the work that we have done in 2018. Recently also, the spacer fucada has been shown to cause a false loss of resistance during attempted epidural block. The other causes of failure is false loss of resistance to air, lack of advanced skills, and lack of a dedicated acute pain service. All of these can be fixed with realization of the appropriate indications, the requirement of blocking visceral pain, and then revivification of the skill set that sadly has been neglected over the past 20 or so years. And then it can also be fixed by just adding a nerve stimulator to the epidural catheter, as we've done for thoracic paravertebral block in 2002 and 3. And then all can be fixed by removing the chief adverse effect. There has been a lot of work over the past 20 or so years to add nerve stimulation to the catheters, and progress has been hampered by a host of negative press. All stimulating catheter complications were associated with the StimuCath and its open coils and flimsy material. This scared practitioners in using stimulating catheters. So everybody was scared of putting StimuCaths into the epidural space to ensure correct catheter placement. Lately, there are a number of catheters that don't suffer these shortcomings of the StimuCath. For instance, the Payunk stimulating catheter and the UltraCath made by Arrow. These catheters have the same material as the epidural catheters made by the same companies, and it has a closed tip made of polymers. Other ways of ensuring correct epidural catheter placement is waveform analysis, fluoroscopy, which is cumbersome, ultrasound, and then there's lately a new technique where a GPS needle tracking system is used. Unfortunately, although very promising, does not tell us where the catheter goes. There is no free lunch, so unfortunately we cannot block the nerves associated with the sympathetics without also blocking the sympathetic nerves themselves. There is a price associated with blocking the nerves associated with the sympathetic nerves, and that is hypotension. So how do we deal with that hypotension? The obvious answer is to treat it. And how do we treat it? First, explain the mechanism of this hypotension so that the surgeons and, unfortunately, some anesthesiologists actually understand it. Then secondly, to remove the cause of the hypotension, which is usually hypovolemia. Thirdly, increase the cardiac output, because on a high thoracic epidural, the sympathetic nerves to the heart can be blocked, and also the sympathetic nerves to the adrenals can be blocked, and that can cause a decrease in cardiac outputs. So we have to increase the cardiac output, And the best way to do this is with a low-dose beta-1 agonist. But we do not treat hypotension of thoracic epidural with pain or any other alpha agonist, as we so often see where the epidural is turned off in cases of hypotension. Intralipid also now is receiving favorable attention for increasing the cardiac output, and in our practice this is now routinely given for patients suffering hypotension following thoracic epidural block. Finally, the fifth requirement for effective regional anesthesia is that we have to have the correct recipient. In conclusion, if we thus treat the patient, we do not use thoracic epidural block when uni or bilateral somatic pain is involved, only when there is also visceral pain. So we use it for the correct indication. We figure out how to revive the necessary skill set for thoracic epidural in our institutions. We use appropriate equipment, and here I would strongly advise the use of nerve stimulators applied to the catheter. We also have to figure out how to manage hypotension, and here again I strongly advise normovolemia, beta-1 agonist, and lipid emulsion intralipid, and certainly not pain. Lastly, we need an active acute pain service following the thoracic epidural blocks. Then, if we do the above, then sure, thoracic epidural anesthesia and analgesia should be the technique of choice for uni or bilateral pain or surgical procedure in the thoracic area or abdomen where visceral and somatic pain is concerned. Again, I thank Professor Carmacher and his team for inviting me to present this part of the argument. I thank you for your very kind attention.